Hi, welcome to You and Your Health. I'm your host, Dr. David Bertone. Today, we're going to talk about a specialty program in medicine, pediatric concierge practice. And our guest today is Dr. Amna Husain. Dr. Husain is a board-certified pediatrician who has set up her concierge pediatrician practice in Marlborough, New Jersey. Dr. Husain, welcome to the show.
Thank you so much for having me.
So I know you're a little bit of an internet sensation and you do a lot on social media. You have a big following and you help educate your patients and the community about pediatrics. Can you tell us about your practice and how you decided to get into the concierge medicine?
Sure. So it wasn't something that I had planned for a long time or anything like that. I was a young mother when I decided to open my practice, and I wanted to work in a more part-time sort of fashion, but still provide a certain level of care. So for me, that meant longer unrushed visits, the ability for patients to reach me even after hours, the ability to be able to have really and completely open relationship with your doctor without feeling that you were not seeing the same person each time, or you didn't have a very personalized relationship, or that the doctor didn't know your children. Essentially, I was looking for creating a practice that was the ideal pediatrician I wanted for my child. So as I mentioned, when I started out, I was a young mother. And so for me, it had to do with trying to create a patient panel that was manageable for me. And one way to do that was actually working outside of the typical insurance model so that the patients could actually, what we call insurance is third-party billing. So insurance is the third party. The first party is the patient. The second party is the physician. Third party is insurance. This way, billing is actually just between physician and patient. Patients still use their insurance for all types of other services, medications, labs, imaging, you name it. But just to get that very personalized, hands-on, concierge level care with the physician, we call it concierge pediatrics.
That's awesome. So how long have you been doing this specialty type of concierge practice?
Well, the practice itself is actually a little over 2 years old. Okay. So it's young. Yeah. I have been in medicine for a number of years, probably a little bit over 5 years, I think, since I've actually been in pediatrics.
Right. So now when you have a new patient that comes into your practice, you typically see them after they're a newborn in the hospital, or they come to your practice, and what is a common workup for these newborns?
Sure. So actually you can change pediatricians anytime. Definitely, it's always good to have a pediatrician when you have a newborn and have that established way before your baby's born, because babies are unpredictable. So don't save it for the last minute. So I recommend parents start looking in their second trimester. But that being said, I've had 5-year-olds transfer into my practice. I've had teenagers transfer into my practice. So anytime you want to look for a different pediatrician, or you are unhappy with care, you can absolutely transfer pediatricians just like you would an adult doctor if you weren't happy with your doctor, for example, or your doctor was retiring or moving away. Mm-hmm. That being said, to the second part of your question, what kind of workup is there for our newborns? Or I think you had mentioned, do I see them in the hospital? So actually with COVID right now, they're restricting hospital visitors. So I don't round on my newborns in the hospital even before COVID. And the reason I don't do that is there's one of me. I always tell families that, babies are unpredictable. So if you have an 8 a.m. appointment to see me, and then I happen to have a baby that's born, your appointment might get bumped, and that can be very difficult for some families. So in larger practices, typically the way that it works is that one doctor really takes on the nursery and sees the new babies in the morning, and then they come in and see their scheduled patients. But if you're a smaller practice like me and there's just one, you essentially pick or choose. So for me, I allow the newborn hospitalists to see the babies, And I used to see my families in the hospital more socially to check in. I'm also a lactation consultant, so I'm able to provide a lot of support that way to new families. But since COVID, actually, they only allow one support person for a family. So in that case, we actually see the baby after they get discharged. Now to the third point, do newborns get a workup? I think that depends on what you would call a workup. I feel like the word workup in medicine often connotates a large degree of medical labs, imaging, perhaps. We don't really do that typically routinely for newborns. There are a few routine things that we do for newborns, usually before they leave the hospital and by 24 hours of life. So they usually get a hearing screen. They also typically will get their first hepatitis B shot. They will usually also have a bilirubin checked to rule out, high levels of jaundice, which can be dangerous for babies. And they also have what we call a metabolic screen or a newborn screen, which screens for devastating metabolic diseases that would, if missed, could be life-threatening. So it's a screen, but otherwise, that's all done in the first 24 hours, typically in a hospital, or if your baby's born in a birthing center. If you come to see me in my office, I don't routinely do a large workup. Usually I just follow those things up, and then we follow baby. And we're very skilled in knowing what are normal developmental milestones and also developmental characteristics for babies. So we don't typically work up items unless there is a problem.
Got it. I'm assuming there's a lot of education early on, correct? For especially new parents and firstborn, and breastfeeding, and when to introduce solid foods. And the other big issue is obviously the vaccinations, right? There's quite a few. Can you talk about that? And how do you deal with those parents that are against vaccinations, and how do you introduce that topic?
Well, I definitely agree. There's a lot of education, but there's a lot of education, I think, every stage. Even if my daughter's a toddler right now, this is my first time going through toddlerhood as a parent. So there's education for me always. It's just a different sort of degree. And I'm expecting. So I'll be back in that newborn phase very soon. And then you're it's tough, right? Just as soon as you master one, they're on to the next phase. So there's always a lot of educating. And we as pediatricians, we're here as advocates for not just the patients, our children, our pediatric patients, but their parents as well. Part of that advocacy work, is education. And you're right. There are a lot of misconceptions about a lot of things. And I think the internet's been great in many ways, but it's also been difficult because you can pretty much find anything you want to, whether it's true or not. So I usually talk to parents openly about vaccinations and start with what their questions, hesitations, or concerns might be, if there are any. I have to say I haven't seen many at all in my practice. I think families respect my open dialogue with them, and they have any questions, they're always free to ask them anytime. But I usually start there. So I don't really have a chalkboard talk I give to families, because not every family might have the same concerns or questions. We start with what their concerns might be, and then we work from there.
Is there a typical time frame for the vaccinations, when they're given, and are they staggered? How does that work?
Typically pediatric practices follow the CDC's vaccination schedule. So that is online. It's a very detailed schedule. It's based in evidence. It's based in what's been studied. But that's typically what most pediatric practices follow.
Is there any special considerations for COVID now with newborns and vaccinations? Is there any talk of COVID vaccine for newborns, or where do we stand with that?
Before we get to newborns, we actually are. So the way vaccination trials work are by de-escalation. So for example, very recently we got approved for 12 to 15-year-olds by Pfizer's vaccine. Moderna's will come, but we're not there yet. So they're what we call de-escalation studies. So essentially you start with the older tier population, then you move down to the most vulnerable. So before we really even get to the newborns, we still have a big population that we're missing, which is 11 to 2-year-olds. They're currently in trials right now and likely anticipated to be approved by the FDA under emergency use authorization in September. Thereafter, we are looking at even younger than that. So 6 months to 2 years of age. Perhaps that data likely come out early quarter 2022, excuse me. So in terms of what to do if you have a newborn and with COVID going around, well, we talk to families a lot about safe practices, especially in the first few months of life, and who should be around baby even before COVID happened. And that's still very important now. So I would say that you would just want somebody who is vaccinated against COVID if they're going to be in your house holding your baby.
And have you seen any young COVID patients at all in your practice, teenagers, or has that been an issue?
Yes, I have. A lot more earlier on, less so as people have continued to distance and wear masks.
Okay, great. How about in terms of the other things like breastfeeding and solid food? What's some of the milestones to transition from breastfeeding to solid foods? What's the time frame usually for that?
You actually don't transition from breast milk to solids.
Okay.
So in the first year of life, typically breast milk and or formula is the main source of nutrition. However, around 4 to 6 months of age, you introduce solids. And then I explain to families that your job with me and helping you along the way, guiding you which foods are good, safe, when to introduce in that first, 6 months to year of life is trying to continue increasing solid intake. And then naturally, because that's what we all move towards as we become adults, and if you can think about as you're a toddler, you move towards more regular meals and slowly increase their comfort and their exposure to different tastes and textures, flavors, all those types of things. So along the way, though, you are still breastfeeding and or formula feeding. There's no really time in that first year of life that you say stop breastfeeding. And even after the first year of life, if a mother chooses to continue breastfeeding, we absolutely encourage it. I encourage families to think about it as a relationship, and that relationship can go on as long as you, the mother or the breastfeeding parent, and the baby choose it to. So there's only really 2 people involved in that relationship, and they get to really determine the rules of that relationship. Now, after 1 year of age, typically is when we say it's okay to introduce another kind of milk. So traditionally that used to be cow's milk, but other families, whatever dietary, religious beliefs that they might have, or just flavor preferences, might bring soy milk, almond milk, cashew milk, rice milk, coconut milk into the house. So those are all options.
Awesome. Okay, when we come back after break, we're going to talk about some of the common pediatric conditions that you're seeing in your practice, and we'll resume right after these messages.
Observe a domesticated human family in their natural habitat, known to their species as the backyard.
Hey, you think I should light it now?
I think it's good.
Yeah?
Oh dear, someone is about to burn a pile of debris that's too tall, which can start a wildfire. Wait, could it be? Blimey, it is.
It's Smokey.
It's Smokey Bear. What a legend.
What's he
Hey,
doing
it's
here?
Smokey. Sorry, it was too high. Right.
Watch as he astutely ensures that there's no wind, and how he removes some of the debris to create a smaller, safer burning pile.
No, you
me to
said,
make it big.
no, you said make it bigger, baby. The bigger, the better.
Take note of
Right.
our fearless furry friend here, humans.
I appreciate it. Fist bump.
Watching you.
Smokey's done it again.
Bye, Smokey.
Only you can prevent wildfires.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Our topic today is pediatrics, and our guest is Dr. Amna Husain, who is a board-certified pediatrician, and her practice of Pure Direct Pediatrics is a concierge pediatric practice located in Marlborough, New Jersey. Dr. Husain, welcome back to the show.
Thank
So
you.
when we left off, we were talking about some common pediatric conditions. One of them is the child that has chronic ear infections. I'm sure it's fairly common in your practice. What are some of the options for these children when things just aren't getting better?
That's a good question. So I think that you have to look at what a chronic ear infection is. Ear infections can take some time to resolve, and the ear will take a few weeks to months to look completely normal after being infected. We do have guidelines in place for what multiple ear infections can look like, either within a 6-month span or within a 1-year span, and then tailor treatment that way. So sometimes if it's a viral ear infection, it's a viral ear infection and it takes its time to resolve. If it's a bacterial ear infection, bacterial ear infections need to be treated with antibiotics. If they're persistent and they're occurring, as I mentioned, within that 6-month span or within that 1-year span, we have a certain number of ear infections we typically keep an eye out for or keep an eye out on or account of, then we usually would refer for bilateral laryngotomy tubes, essentially ear tubes to be placed by an ENT surgeon.
And that process is fairly common, correct?
We do see a decent number of children who get it. It's overall well tolerated. Any ENT surgeon can absolutely guide parents on it, but this is a very something that's pretty common within the realm of pediatric ENT.
Okay, great. Another common condition I would assume is food allergies. How is that established, and is that something that you refer out for and help with education?
Sure. So it is rising in prevalence. There's multiple reasons why they're rising in prevalence, and the cause of food allergies is very complex and multifactorial. A lot of families are quick to diagnose an allergy themselves, and I really don't recommend it because you end up cutting foods out of your diet without any evidence. And the evidence I'm looking for is actually a test by an allergist. So allergists do prick testing or patch testing. We do refer out for it. Typically food allergies are diagnosed by prick testing. These at-home testing kits and just these assumptions that people sometimes make actually can end up having worsening effects because you're cutting foods out of your diet that don't need to be necessarily cut out. So I always recommend you go to the most educated expert in that field. So usually your pediatrician can help coordinate a referral to an allergist if needed. And then thereafter, we can also continue to help manage a food allergy if needed.
How about newborn rashes or rashes that may develop early on in a child's life?
So there's a lot of rashes, a ton.
What are the most common ones that you would see?
There's so many newborn skin findings. We literally have a colloquial term in pediatrics is called normal newborn rash. We know what is typically meant to have miliaria, infantile acne, neonatal acne, erythema toxicum. These have really long names. They can seem really scary to parents, but initially newborns do have some rashes that can appear. I think what's more important is, when do you worry? When do you call your pediatrician? And I always say that if you're a new parent and you're worried about something, it's okay to call your pediatrician. We would like to hear from you. Or in my case, I even have parents text me so they can text me pictures. And that's more helpful when it comes to rashes, rather than, have me here describing them, which can be kind of hard. I feel like in dermatology, a picture is like 1,000 words.
Yeah.
So when it comes to what things to look out for, typically it's going to be a rash accompanied by symptoms or red flags, fever, itchiness. If you had other concerning symptoms like difficulty breathing, inability to tolerate oral intake, vomiting, looser stools, so red flag symptoms with your rash.
Is there common things that that you can do, either like a low dose cortisone, or you're allowed to use any of that stuff?
It depends. You can, but it really depends on the rash. So I don't really recommend home remedies until I know what I'm dealing with and treating, because some can get worse with steroid and some can get better with steroid and some won't change, and you don't really need to rub anything on it.
Okay. Another big area is autism, the autism spectrum. Obviously, the incident rate has been going up. What are some of the signs for parents to look for, and what are some of the things that you look for during your milestone screenings or annual well checks for possible signs of that?
Sure. And I want to point out that when we talk about the autism incidence increasing, we also believe it's the fact that we're getting better at screening, which is actually really important to bring to attention. Before people jump to just the rates increasing, it's actually the fact that we're getting better at diagnosing it, which is incredibly important, because one of the hallmarks when it comes to treatment for autism is early therapy. So early applied behavioral analysis therapy. So autism, as we mentioned, has to do with behavior. So social emotional behavior typically is what we look at. And there are screeners that we have that are standardized that we administer at certain times. So 18 months, 24 months, 30 months. But along the way, you can actually always screen for autism. There are certain telltale signs, figures, red flags that we will see. And I think that if you have a concern, just as I've mentioned, bringing attention early to it rather than later is what we know is most beneficial.
Great. How about nutritional wellness and things like supplements? Is there ever a concern based on the child's nutritional habits that you might look into supplementation?
I think it depends on what kind of supplement we're talking about. So when I think of supplements, I think of the adults who supplement their diet with maybe protein shakes or additional vitamins or over-the-counter things from perhaps like GNC or something, or the vitamin store. No, we don't do that in pediatrics. Absolutely not. It's completely unnecessary. And you should not be trying to put your child on a supplement without talking to your pediatrician first, because these are not FDA regulated and your child is not an adult. They're not little adults. So you want to make sure what's going in is actually safe. And your pediatrician is going to be the one who's going to guide you on that. So I don't routinely recommend supplementation of anything. Now, when you're talking about nutrition and a child's falling off their growth curve, we look at a couple of different things. It's not always just the diet. So we look at organic diseases first. So diseases of the body that could potentially be ruled out. And then also look at the diet together. There are things you can absolutely do to supplement, but I think it depends on the age of the child. So if I was worried about a newborn's nutrition, that supplementation is going to look very different than if I was worried about a 2-year-old's versus a 9-year-old's diet versus a teenager's. So I think that.
Yeah, do you still utilize the food pyramid for teaching nutrition? with the,
Not really.
not really? Okay, just a well-balanced diet, especially in the toddlers and, teenagers, to try to get nutrition across the spectrum of
Right. And I
necessary food
encourage
intake.
families to remember that look at the forest, not the trees. Not everything is going to look amazing every day. But if you look at the end of the week and your child's overall been eating very well and balanced, then that's a win for you as a parent. So every child's different. Of course, picky eating is potentially possible, but that's not to say that every child's going to be a picky eater. You
Yeah.
might have a great eater, and that's okay. And that's also encouraged.
So obviously you'll get those kids that are picky eaters and they, the chicken fingers and mac and cheese, and they don't like the broccoli and the other stuff. But eventually you slowly introduce things and they come around. to
Right.
some
You
of it.
continue to keep introducing,
Yeah.
keep introducing. Don't make it a fight. Try to introduce in many different ways, whether it be raw broccoli, steamed broccoli, roasted broccoli, grilled broccoli, to use your example.
Mhm.
Try again if the first time it doesn't work, and don't try the next day. If you're really like on day 3 of broccoli, gosh, don't try day 4, but give it 3 or 4 weeks and try it again. And don't
Mhm.
make it a battle of wits. You're just going to get annoyed. And don't get offended. Again, there's so many ups and downs to it. And your kid who hates broccoli might just love Brussels sprouts. Every child's very different. So instead, focus on trying to eat different colors if you can. So stay away from that white diet of white rice, white potato, white chicken nuggets. And I instead say that, yeah, of course, chicken nuggets every now and then are okay. A baked potato's okay every now and then. So are French fries. Just you don't want that same thing every day.
Yep. Okay. How about diabetes, juvenile diabetes? How is that usually detected, or some of the signs and symptoms that parents should look for to bring to your attention?
Sure. So the two diabetes, type 1 and type 2, are prevalent in pediatric population. Type 2 is typically associated with obesity, and type 1 is typically an autoimmune disease. Both, your body is not responding well to insulin. And the second one, your body's not responding to insulin. The first, your body is essentially attacking the pancreas and autoimmune. So you're really not producing enough insulin. Both are going to have devastating effects of high glucose. And with children, they can be as young as I've seen 15 months, and through teenagerhood and through a young adulthood. And I've even had adults your age who presented with type 1 diabetes. Not to me, but that I've known of.
Mhm.
So autoimmune diseases can occur. They can happen. But they'll both present in very similar ways, that you're having the effects of too much glucose in your bloodstream.
Okay. Now you have a child and they're getting older and they're in high school. And when do they transition out of pediatric practice into an adult practice?
Sure. So if you are in a larger city, you can actually look for an adolescent doctor for your child once they become around 11 or 12, that tween age. They're still pediatrics trained. They've done a fellowship in adolescent medicine. You can also 100% stick with your pediatrician, though, your general pediatrician. Typically, some pediatricians will see up to 18, some see up to 22, and I have seen up to 26 in the past. So some of these children are on their parents' insurance until they're 26. And so when I've taken insurance in the past, I've even seen 25-year-olds.
Cool. Well, Dr. Husain, thank you so much for taking the time to join us today and help educate the public about pediatrics and pediatric concierge practice. So again, thanks for joining us on You and Your Health. Until the next time, I'm Dr. David Bertone.